Welcome. Good afternoon, and welcome to the virtual town hall for April 17th. For the duration of this meeting, we've suspended our mask policy here in the auditorium so you can better understand us, and we're continuing to assure social distancing for the few of us in this large auditorium. Let me thank you for joining us today. As many of you know, earlier today I shared a message with our leadership team about the dramatic effect that COVID-19 has had on our organization. Since mid-March, we've seen significant changes not only to our clinical operation, but also to our financial situation. Several factors have rapidly changed our revenue and expense outlook. We've had to delay surgeries, elective surgeries, and close many of our other services, which is of financial impact, but also importantly means that some of our patients who need care have not been able to come here and get that. We've had a much lower occupancy in our hospitals, around 60%, versus our usual 90% or higher, again, to provide for the COVID patients who would need to come to the hospital. And we've built a number of new ICU rooms, which has been great in many senses, but expensive. All these factors have and will continue to have a significant impact on our financial health. And clearly this year is going to be very different than previous years. But just as we have come together to manage the clinical aspects of this pandemic, we need to bring our teams together to help manage the financial implications, to recover our losses, and to learn from what we have learned about organizational efficiency during this period of time. Many good things have happened during this time, and I thought it'd be interesting to you to share with you a few photographs. As we continue our battle against COVID-19, it's important to celebrate our successes. Beginning today, when a COVID-19 positive patient is discharged from the hospital, we'll be playing a musical excerpt from Hail to the Victors. This is just one small way that we're celebrating our patient's journey back to recovery and in health, and the exceptional work of all of you who provide care for our patients. I wanted to share another way we're thanking our team members. You've heard about the hashtag Hail to the Front Line social media campaign. This is now going to be taken one step further with a video that recognizes our entire Michigan medicine community as members of our front line. All of you play essential roles, make absolute commitments, and take the very best care of our patients, and have made that a reality. And this video, thanks to donor funds, will be played on television as well as on some well-placed billboards. So I'd like to thank our generous supporters for making this possible. And the goal of this is as a tribute to all of those who have all of you who have played such a major part of our tripartite mission. To get a sneak preview of this ad, look for the link in today's daily COVID update. Finally, I want to tell you about one very good critical milestone that was reached this week. On Wednesday, we had more COVID-19 patient discharges than admissions. It's been a long time, and we've been seeing flattening of the curve, but this is evidence that we're either further along in our course of this epidemic. Thus, again, I'd like to thank you all for your ongoing efforts, to your commitment, to your dedication, and to your passion in providing the best health care that can be provided anywhere for our patients. Now I'll turn it over to Jeff Desmond, who will provide an update on our census and clinical activities.
Thank you, Marshall. Happy to be here again and provide you with some information about where we stand and a little bit about where we stand related to our projections, what we see for the future, and kind of how transfer patients and other things have contributed to that. So you've seen these slides before, not the exact same slides. These are different data, but the same structure. So you can see the United States, again, still leads the world, both in number of cases and in deaths. Michigan is fourth in the United States with over 2,000 deaths and almost 30,000 cases in the state of Michigan. And again, you can see from the map that this has really been concentrated to southeast Michigan. That's still been the experience, though you can tell from the dots that things are kind of moving out across the state. I can bring my arrow over. Things are kind of moving out across the state. If we look at what our local experience is, we now have a census in the hospital of a little over 200 patients, and about half of those, 98, are currently in intensive care status. You can see from the curve below that the total number of positive tests that we have has started to taper off, and I'll talk a little bit about that. Last time we spoke, we talked about potentially reaching the top of the curve or looking to the other side of the curve. We have a different analogy for you today that I think we'll talk about. You can see also from the map of Michigan that this is still primarily a Southeast Michigan issue, though certainly involves virtually every county within the state. People asked about what the demographics are and what the experiences of the patients with COVID have been in the hospital, and so we provided this data to kind of show that it's primarily an adult disease, as you can see. So very few people under the age of 30 and very, very few under the age of 20. And you can see the hospitalizations, about half of the patients in the hospital are in ICU status, half the patients are on general care floors, and that stays true for pretty much about every age range. The yellow being patients in the ICU, the green being patients in non-ICU. And our length of stay is about 4.5 days for non-ICU patients, about a little more than 9 days for ICU patients. So far, we've seen about a 16% mortality rate in patients that have been hospitalized with COVID here at Michigan. That said, that mortality rate and some of these length of stay numbers are probably underestimated because these patients are still in the hospital. So as a total, we've had we've had 41 deaths of inpatients related to COVID in the system. And you can see we've had over 230 discharges. You know, a couple things really made the difference between where we were projecting to be and where we ended up in our actual experience with COVID patients. One of those was social distancing, and I'll talk about that at the end, which really had a larger impact than I think we anticipated, and the aggressive social distancing really helped flatten that curve early and then continued to flatten the curve. The other thing that changed our experience here was really the transfer patients that we took, and this was coordination with other health systems across Southeast Michigan to help respond to that surge in patients, really in the Detroit area and in other parts of Southeast Michigan, so that we would be able to provide the services that we offer to patients in our region. So these are some summary statistics really over the last several weeks where we have accepted a number of transfer patients. And you can see a number of those transfer patients are COVID related, so over 250 COVID related transfer patients, and still almost 190 non-COVID related patients, because we offer care to those that need what we have to offer, specific services or care that's not available elsewhere for both COVID and non-COVID patients across the region. Some of this data is limited because some of the ED to ED transfers are not well captured, but overall it's directionally correct and gives you a sense of what the impact there has been. This shows what the accumulation of of those patients have been over time. So our total accepted patients, almost over 400 and some patients, as we saw before, with still a significant number of non-COVID patients accepted, and really providing that care and that resource to those who are in greatest need. I think this is the story now, is that things, we've probably reached the top of the curve with the social distancing that's taken place and limiting the spread of the disease really in Michigan. So we've had about 512 total hospitalizations. You can see that about 35% of that has come from transfer patients. About 32% of our patients that have been discharged so far have required an ICU stay. And about 64% of the transfer patients required an ICU stay. So these transfer patients really brought a higher percentage of ICU care to us than I think we would have achieved if we had not been taking patients from other parts of the other health systems in other parts of the region. This is some data from the Southeast Michigan counties just in the last several days, and shows you that similar part of the curve that that we saw with our census admissions. If I just go back, we're really seeing flattening out here at the top part of the curve. And again, this is similar across other counties. This is Detroit and Wayne County, Oakland County, and you can see Washtenaw and Macomb County really have kind of flattened out here. So I think this is where we are. We're on the plateau, and I think we're going to be on the plateau for some period of time. And what I mean by that is that we're going to be managing COVID-related disease and non-COVID patients that require care in the health system for some time to come. And I think that's going to be important for us to understand because it's going to require us to do things differently. And I think Dave Bollinger is going to talk about that a little bit at the end of the town hall. We're starting to think about how to resume some services and some care to those patients that have had their care deferred during the COVID pandemic. We have some capacity in the hospital to be able to do that and in the health system. And we need to understand how to do that in a safe and effective way, but also to limit the spread of the disease while we deliver that care that's been deferred and really reduce harm related to deferred care. So I think we're going to be on that plateau for a while. And as I said, I think that's going to require us to function differently going forward. And I think this is going to be one of the things that's going to be different. Social distancing is going to be with us for a long time, I think. I think other changes that we've made to the healthcare system in order to be able to safely provide care, masking, gowning and PPE, testing of patients, these are things that are going to be with us for a long time so that we can continue to provide care to both the COVID-related patients with COVID-related disease and those with non-COVID disease and keep both our employees, the patients, and our healthcare workers safe. So with that, I'm going to stop here. Lorraine's going to talk a little bit about testing. Thanks.
All right, so we've gotten a lot of questions over time about the tests that we're performing here to diagnose COVID, both the molecular tests and some of the serologic tests that are being developed. And so I wanted to take just a brief moment to do an update on that. So the molecular testing that we do for COVID is actually a PCR, polymerase chain reaction test, and it's specifically looking for RNA from the SARS-CoV-2 virus. Its primary role is really for the initial diagnosis for people with symptoms of COVID. And it has an unclear, or I'll say at least a developing role for screening in asymptomatic patients and possibly for determining when patients are no longer infectious. The PCR detects RNA, it detects the RNA protein, but it doesn't tell us whether the virus is replicating, whether it's alive or dead. And so we're making some assumptions and correlations based upon RNA tests while we wait for more science to tell us when patients are no longer infectious. This test is really quite good. When it's positive and the patient has symptoms, we can believe that it's positive. But there are some concerns about false negative results. The test itself has very good analytic sensitivity, but the sensitivity really also depends upon a number of other things, including the specimen type, whether the specimen is a nasopharyngeal swab, an oral swab, or other specimens, and specifically upon the collection technique. So it's very important that whoever's doing the specimen collection gets a good sample, particularly from the NP location. Also, the test may be less sensitive, falsely negative, if the viral levels are too low right at the very beginning of illness or possibly later in the clinical course. And in asymptomatic folks, we really just don't know what the sensitivity is. And we're learning that, I think, as more and more health systems begin to test asymptomatic people. Our laboratory has gotten some information about the sensitivity of the tests that we perform here. And when we have patients who have had multiple tests done, it is quite rare that we would see someone to be tested as negative initially and then on further testing to test as positive. And in the patients who have had multiple tests done, we've only seen that in 4 to 5% of those patients. Compared to the literature, that's quite a bit better. We've seen the literature report anywhere from 3% to 30% false negatives. The other test for COVID is a serology test. And as you know, serology tests really are looking to identify the presence of antibodies against viral proteins in blood. This is not a diagnostic test to tell you whether you're infected for the most part. It really is mostly an attempt to be used to tell us whether we've been exposed to COVID and had COVID infection in the past. There are many, many tests available, more than 40 tests that have been developed, and all of them have variable performances. None of them are FDA approved. And so it's very important for our laboratory to determine which is the best test that we should use for this purpose and for our patients. And because of that, our lab is evaluating several serologic tests and assays for in-house use currently. Serologic tests are likely to be important as we move forward in this epidemic, but there are many unknowns regarding the clinical applications and also the public health applications. We know that these tests may detect those who've been infected and have now recovered, but didn't have any PCR testing done at the time of their illness. We also know that the IgM type of serology may be able to augment sensitivity of testing in those who are PCR negative, but still considered to have symptoms compatible with COVID. And I think we'll learn more about that as we begin to use these tests in the future. There are some concerns about cross-reactivity with other coronaviruses, so the other types of coronaviruses that can cause common colds on a seasonal basis. And most importantly, I think it's really not known whether or not a positive serologic IgG test will predict protection from future COVID infections, and in particular, how long it might predict whether someone is immune. So I think we're going to be getting a lot more experience, both from other health systems, other countries, and also within our own health system about how well these tests perform and how we might use them in our future planning and for patient information. Now I think Nancy is going to come and talk about what we've been doing from COVID from a nursing care perspective.
Thank you, Lorraine. So this is our nursing update, and I'd like to tell you some stories and some things that are going on. We continue to rise to the daily challenges that we have regarding the pandemic situation and how our nurses are being deployed. The new staffing model, we continue to refine. There are huddles daily to look at staffing and critical needs for staffing. We do adjust the model according to the needs. And that's really off staff feedback. And so continue to work with your ACNOs as well as your clinical directors, and we will continue to adjust as needed. The field hospital planning is wrapping up. The information that we've gained will be valuable as we move forward. They're in the process now of putting a manual together for future needs if we ever need one. It's been a valuable experience. We're all glad that we didn't have to open it, but the exercise itself will be very useful as we move forward with any potential critical need for a field hospital. One of the shout outs today is really to occupational health. They have been in this 100% from day one. We have had challenges in the past to get fit testing done, and just since the end of March, they fitted over 2,500 people for fit testing. 2,000 of the masks were the white ones, and about another 500 were the blue ones, and that's really a heavy lift for that department because historically we do about 300 a month. And so when you think about 2,500, that is really, really pretty phenomenal. They do that, once again, to protect our employees, to make sure that we have the right equipment, that it is fit tested properly, and that it keeps our employees safe. That fit testing is really the key to your safety. I'd like to do some thank yous. We've been very grateful for the food that's been delivered to the floors. There's been over almost close to 6,600 meals delivered over the last couple weeks. Additional care packages are now being sent out. There's been 4,000 care packages sent out to the units this week. Another 4,000 with granola bars, Gatorade, water, things where people can grab something quick to eat. I know that next week our ambulatory care areas will be receiving the packages, and lots of people volunteered their time to fill those in the cafeteria and handed them out as well. So we continue to assemble those. In addition to the meals, as you can see, our community has provided a lot of philanthropy money for the meals. There's a very great process going on who is getting meals and when they get them. Some areas have requested bagels in the morning, and so we're also trying to provide bagels for a unit in the morning that are on lists now. I always have to give a shout out to our Kathleen Roberts and Nicole Figueroa regarding nursing resistance and self-care. We know that these are challenging times. They have done amazing work rounding on units and really allowing employees to vent and also to support what they need to get through the day. Often they also do services, e-phone consult services as well. They're very supportive to all our staff, not only nursing, but throughout the house. The guide to well-being during the COVID-19 panic is on the website, and if you would click onto that website link, it'll give you all sorts of resources that you can use to support yourself as well as your coworkers. I'd like to do shout outs, and so PACU must feel like a yo-yo. We opened them for an ICU, and now they're moving back towards PACU care as we continue to launch and ramp up our surgical volume. Noreen Myers, the clinical director, and this is a quote from her, that PACU rocks each and every day, no matter what is thrown at us. We have all taken the high road and should hold our heads high and be proud of the resiliency and strength this unit has and continues to demonstrate. We are Michigan medicine at its finest. So thank you for PACU. I also want to shout out to the emergency department. They were really our frontline people that opened their arms to our COVID patients early on in this experience that we are going through. I love their humor. I like to laugh, and I loved the last one with the dog being AES's Rough. I thought that was really cute. Also, the new uniform across the house really is now our PPE as we continue to take care of patients as they enter our emergency services. They have been adaptable to the needs and the rushes of people and surges as they've come in. In the meantime, they continue to learn new skills of proning patients, and they really function as a high-functioning team. These are just some examples and pictures of them learning how to prone patients to ensure that they have good pulmonary hygiene for their patients. This one is one where they're doing airway management. As you can see, they take the time that is available to them to continue to brush up on their skills. And another picture here of a nurse getting ready for triage and PPE. I liked the words to live by that the adult emergency services came up with. It's, you can't calm the storm, so stop trying. What you can do is calm yourself. The storm will pass. And they have this on one of their bulletin boards, and I think it's fitting for where we all have been on this journey with this pandemic. The emergency service is about the team, and it's a tight team, and we truly appreciate all the work that they do. We couldn't do this work without ABCC. As Dr. Desmond talked about, we've had 500 patients admitted into this facilities over the last few weeks. And ABCC works closely with the Super AOD program to ensure that we get patients placed at the right level of care as they come into the organization. Not only the ABCC, but the CVC bed management teams are part of that work, and we couldn't do the work every day unless we had strong teams in those areas. So a shout out to them as well. Great job. I know last Friday, we kept part of that team here till 9 o'clock at night in the command center, helping us move patients around. So thank you once again. I'm going to give some shout outs because this really defines our purpose of what we are as a nursing community or even as a community here at U of M. And some of these are just nice testimonials of what our own employees say about each other. Oftentimes we hear negative things, and I have to tell you, being in the job I'm in, we hear all the problems. They all come to us. So it's so nice to see how we treat each other and how this has changed, I think, in many ways, some of our culture. This is one from Brooke Christopherson. She's an RN nurse practitioner, and she says, I would like to send a shout out to the medicine pulmonary team that has successfully transitioned from moderate care to ICU level. Their dedication to independent learning and updating their skill set has facilitated smooth transition for 8D to go to moderate care to ICU care. The NPs and PAs on this team have tirelessly worked to provide outstanding care to some of the hospital's sickest patients. Thank you. This one comes from Brenda Bell. I'm a moderate care RN currently working in CVC 5 ICU. Thank you, safety monitors, for helping to reduce our anxiety, keeping us safe during this pandemic. For me and my workday, you have made the biggest difference. Thank you, U of M, for providing them so we can be safe. You are all the best. Another one comes from nurses that work in Livonia Specialty Care. Roger Miller and Stacy Roth were redeployed to work in UH and CVC Hospital, including the ICU. Brenda speaks of some anxiety they had, but they would never know the nurses' anxiety because they're just really about doing the right thing and standing up for what's right. So thank you very much, Roger and Stacy, for your volunteering, and Brenda for acknowledgement of your coworkers. Another one is from another nurse practitioner, Denise Stepka, who made sure that hand-sewn scrub caps for her pulmonary med colleagues were available. Another shout out comes from Lisa Anderson about the rapid response team coming to help prone patients on 8D ICU. Kim Berry, Caitlin Roberts, and Caitlin Cho, all 8D nurses who adapted so quickly to the dramatic changes of their unit and helped the ICU nurses care for the critical care patients in their area. So thank you all. This one is from Michelle Durham, who's one of our nurse leaders, and she's acknowledging Vicki Walls, who's helping her community inside and outside of Michigan Medicine. She sends boxes of sweet treats weekly to the staff in the RICU from a local bakery. So it's a twofold gain, one for the community and one for the staff up in the RICU. Another one is a nurse from 4B who's been deployed to 4D. Have been nothing short of amazing. They have totally gone above and beyond. They are all welcome to this family, and this is submitted by Rebecca Landfair. Another one from Judy Baker. Shout out to the Blue Team in the Cancer Center for being consistent in managing the oncology needs while managing COVID-19 fears. Workload increased due to the providers being deployed has left a core group of nurses to deal with increased workload, and they are rocking it. Thank you for stepping up, Blue Team. Our patients appreciate you. This one is from Sheila, and she talks about thank you to all the frontline care workers and my fellow nurses. I'm so proud to be working at Michigan Medicine during this time of uncertainty. It is great to see everyone coming together during the greatest time of need. Stay strong. This one I just got last night, and it kind of just warmed my heart. We have music therapy, and they're often in the cancer center, but they got sent up to the RICU. And this is from the nurse leader, Julie Juno. Thank you, Donna and Bob, for visiting the RICU today. Your positive spirits and the gift of music lifted many souls today. Hearing the soft, gentle music play in the background made this feel like a different space for that moment in time. And you can't really tell from the photo, but on Bob's knee is an iPhone. And what the nurse has done is she has another iPhone in the patient's room. And so the music therapy is actually given at the bedside. And so how we use the technology out there and how innovative nurses are to be able to fill in gaps in care and needs for patients and families is just so important. Often the technology with iPhones and things are also being used to connect with families. I'm going to end with just a few more words. These are our stories. They give us purpose for the work we do and why we chose our profession. As difficult as it is to face the challenges every day, we rise to show what we are made of. You are the Michigan nurse. I am proud to say that you show up for work every day, never backing out of what lies ahead of you, and provide care to the sickest patients. Many of you might say the sickest patients you've ever taken care of. You do not complain. You figure out ways we could meet the needs of our patients, families, and each other. The emotional support necessary on some days is a heavy lift for anyone. Somehow you place every patient's needs in front of your own and find innovative ways to promote care due to the new challenges faced with this population. Not being allowed to have a family visit a patient at their sickest time, you find those ways through iPhones, iPads, or FaceTime to connect families with their loved ones. Having music streamed from Bob to the bedside shows those creative ways to connect our patients. You are all my heroes. I am grateful for the work you do for our patients, community, and the support you have shown to each other to get through this pandemic. We are one strong nursing community, and I am proud and inspired on how we have all come together. We will come out of this, and we will be stronger than ever. Thank you so much. Thank you, thank you. And next is Dr. Spollinger.
Thank you, Nancy. So I'm here to talk about future planning. And Yogi Berra once said, "The future ain't what it used to be." And no time can I remember is that a more appropriate quote than now. Trying to figure out how this. There we go. And as we begin to plan for the future, you heard Jeff say we're going to be on this plateau, and we're going to be dealing with both COVID and non-COVID. I think it's helpful to know what our guiding principles are as we begin to plan. And one, I think at the top is that we need to maintain both patient and employee safety are paramount as we begin planning for this new reality. We will have to maintain both access for COVID patients as well as for a possibility for surge capacity. For those that you have, kept track of the news, we are seeing surges of patients in places like Singapore and others as they've begun to lift this, not necessarily the social distancing, but as they've tried to open up their economies. And we will have to do the same. We'll have to maintain, we will have COVID patients that will need care here, and then we'll also see little hotspots, I think, around the state, as well as some surges as we cautiously try and open up the economy. We also have to increase the access to our non-COVID patients. We have a lot of patients that we have delayed care, and we need to look carefully at that group of patients in order to provide care so that they don't incur increases in morbidity or mortality. And so we need to look through that, look at those set of patients and meet their needs. And we anticipate that there may be a surge of patients as we begin to open that up. And finally, as we are a state of Michigan, we are a state institution, and we remain committed to the citizens of the state. And I think that the data that Jeff showed as we took patients from around southeastern Michigan and streamline processes in order to get rapid transfer of patients here, exemplifies our commitment to the citizens of the state. As we do this planning, we are going to have, we're going to have to balance priorities. We're going to have to balance the need of patients, both local and statewide, with the surge of the non-COVID patient needs. We are looking in this next week to gradually resume some surgical and procedural activity, focusing on those patients that we think are at risk for further deterioration of their conditions if they don't get this done in a timely fashion. And while we do this, we also have to recognize that we have finite resources, both PPEs, staffing. We have testing reagents and swabs that we have to balance. And then, of course, Marshall mentioned that we also have capital constraints given the financial impacts of this pandemic has had on our system. And we'll need to balance all these things as we lay out our plans. We also, I think, have to balance a number of things that we've discovered in this process. I think most of us have been amazed by the rapidity with which we can make decisions, the efficiency with which we've been able to accomplish transfers, and some of the facility and other, putting together care teams to meet the needs of these patients with rapidity that we've not seen before. And we don't want to lose some of those positive things, but we have to balance that. We all want to return to what we have thought of as normal. We want to return to normal, but that I'm afraid that's not really where, when normal is going to return. I'm going to talk a little bit You heard Jeff talk about social distancing and how it makes a difference. This is from University of California, San Diego professor, which says, if you have one person and it affects on average 2.5 people if you don't have social distancing, and within 30 days you have 406 people infected, and that 2.5 people is often referred to as the reproductive number, or some people call it the R naught number. If you have less exposure, you can see you get less people infected, and then if you get 75% less exposure, you can see it really makes a dramatic impact. It's estimated that California has reached a 50% less exposure rate through their lockdown, which has really dramatically, flattened their curve. But it also has an impact on when we can return to normal. So it's estimated that if the R naught number is 2.5, which you saw a slide of before, we need somewhere between 55% or 60% community immunity. Sometimes you've heard it called herd immunity, in order to return to the way we functioned previously, that we don't have social distancing, that we wouldn't need masks. And there's only 2 ways to get that level of immunity. One is through vaccines, and the other is obviously would be a catastrophe, which is to have that percentage of our population get the COVID disease. And so I think that, but the other thing I should mention is that last week out of Wuhan, there was a report that the R naught number for COVID may be closer to 5.5, which means that we'd have to get to 85% community immunity in order to resume normal functions. So really, I think it depends on getting in a vaccine. Now, I will say there are 5 phase 1 trials, and I heard yesterday that Tony Fauci said maybe by the end of the year. I think what people are thinking, by the end of the year, a vaccine may be available in phase 2 and phase 3 trials. But it is going to be a time before we can get there to get this level of immunity. And I think that we have to think that we're going to be dealing with this for a while. Now, I don't, it's easy to make predictions, especially if people don't hold you to them. But it's likely that we're going to be dealing with this for, I'm estimating 2 years. Maybe I'm hoping that I'm wrong and it'll be less. But I think we need to plan as if we're going to be dealing with this for a while. And I will say normal operations are not likely to be the same, at least for a while. Certainly, we'll be doing more virtual care in order to protect patients and to protect providers. We've already, last week, did 8,000 virtual visits, which last year, for the whole year, we did 4,000. So we've already changed the way we provide care, and this will continue. There's also been a lift on the statewide boundaries, and so it's likely that we'll see, this not just statewide, but national people providing virtual care. We need to maintain, you heard Nancy talk about ABVC and the super AOD, that maintain the coordinated transfer function that we've created, that has made transfers much more efficient, both from the patient's perspective as well as from our perspective in putting patients into the areas where we can meet their needs. I think when I look at the functioning of the command center, as we wind down the command center, we need to take what was best of the command center and insert that into our daily management and leadership, huddles that we have on a daily basis, so that we can, again, solve problems at a more rapid rate and meet the needs of both patients and employees as we move forward. And we've talked in the past about having a 24/7 by 365-day hospital. I think we need to plan for that, both because of the increased activity that may come from COVID patients, as well as the demand, pent-up demand that'll come from the non-COVID patients in order to meet their needs. And I'm also thinking we'll have to have 12 hour by 7 day a week, 365 ambulatory services. Now, not all of those may be face-to-face, they may be virtual, but again, to meet the demand of patients as we begin to, to open up to usual care. I think in the future, we'll have to have better, enhanced home care and monitoring of patients that have been discharged in order to head off decompensation and treatment so that they utilize inpatient resources. And then we have to also, begin to utilize our network partners, because the number of hospital beds is finite and we need to utilize services wherever we can provide them. So that's all I had to say. And as I would say, is we're putting together teams to look at this, to plan for the future as we know it now. And we will continue to make adjustments there. But we have to deal with the new normal, as some people say. So now we're here to the question and answer, and I think I'm going to ask Lorraine to come up first. She seems to be the most popular, has more questions than anybody. So the question is, can you release safety data and studies on recycled N95s, and have they been tested for cross-contamination or safety? Do you know?
Yeah, I think we actually have a lot of data on the masks that we have done reprocessing on. There's data on the type of reprocessing that we're using now, which is a UV light reprocessing with moist heat. And that kills 99.7% of the influenza of a surrogate virus, which was influenza, that we used on the mask. There's also fit testing information and filtration information that's been tested and shows that these masks remain safe from a filtration perspective, as well as from a fit testing perspective. I think that information is on our website. There may be more detailed information if people are interested in that, and I think that we can share some of that as well. I think there's an interest in sharing it more broadly across the state to help some of our partners.
So there's a number of things here about testing, and some of those you did kind of answer in your presentation, but I'll ask them anyways. How many patients are we currently testing per day, and what is our goal?
Yeah, that's a really good question. So the number of patients who've been tested per day has varied over time. I would say that on average, we're probably testing about 300 patients a day in the recent time period. My goal would be able to test twice that number of patients. Clearly, that would be dictated about who needs to be tested based upon symptoms, but we're talking about testing in other circumstances as well. The primary goal, the first goal, I think, would be to open up testing for symptomatic patients more broadly in the ambulatory setting. And then the second goal would be to determine where asymptomatic testing might help us be able to do surgeries in a different way and potentially handle admissions in a different way.
Yeah, this one, are we continuing to ramp up our testing ability? And I think the answer to that is yes.
The answer is yes. I think that we have a lot of testing capacity in the laboratory setting. If we were able to test patients, and we could probably do up to 1,000 a day is what the laboratory tells us. What we're limited by in particular is the swabs, and the swabs have to be a certain type of swab, a certain shape swab, to be able to do the testing in an accurate way. That's the main limitation at this point.
So I think this one is helpful to reinforce, which is, will antibody testing begin for employees so we can safely volunteer for front lines? I think, as to what that means when you have this.
Right. So I foresee that we will have serology testing available soon, and that's in weeks, I would say. And how that's used throughout the health system, I think, has yet to be fully determined. But I do think that there is a role for serology to determine if you've been infected in the recent past or during this particular part of the pandemic. But what we really don't know is how much that's going to predict immunity or protection for an individual healthcare worker or someone in the community. And I think that we will know more about that in the future, but right now we're using information from other viruses and other epidemiologic studies. And so I don't know that we'll be able to say that it's safer for you to work because you had an IgG test positive versus someone who had a negative IgG test in the near future. My hope is that we'll have information as a society that will be able to help us with that in the future. But right now, I think there's a lot of unknowns about that.
Yeah, and I guess I would just add is our approach will be to continue to require PPE for all frontline workers until we really know that the IgG confers immunity. Otherwise, we would be putting people at risk.
Correct.
Reports indicate a vaccine may be ready in the fall. Others suggest 2021. What should we expect? It's a hard question.
I think that we're moving, the scientific community is moving more rapidly than they've ever moved to create a vaccine in real time for this pandemic. I think that we still want to go through the steps that we typically do for phase 1, phase 2, and phase 3 vaccines so that we can have a safe, effective vaccine. And my guess is that it would not be ready by the fall. And I think that 2021 is a more realistic time frame.
Do you want to say anything about these vaccines being mRNA vaccines versus what historically?
I'm not probably the right person to comment upon the types of vaccines, but there are a number of vaccines that are in development, and many of them have different approaches to the way that they provoke immunity.
Okay. Is blood type related to susceptibility to COVID and severity?
So I've heard some case reports and some information that blood type may be related to severity of COVID infection, and that the O blood type may be correlated with less severe disease, and the A blood type may be correlated with more severe disease. I think that that remains to be borne out in large studies. It's interesting to think about, but I think that time will tell as more studies, if more studies actually corroborate that information.
Thank you, Lorraine. Jeff? Will all surgical patients be tested for COVID preoperatively?
So we'd love to get to the point where we could test all surgical patients or procedural patients before either procedures or surgery. As Lorraine spoke to that, our primary constraint right now is testing media and then testing capacity. So we are putting together a risk-based testing algorithm for preoperative patients so that we can get started doing some procedures. But we'll have to see what our supplies of testing will be before we can test all preoperative patients.
Are we going to have separate units in the hospital for COVID patients?
Yeah, so that's a great question, and we're in the midst of trying to think about how best to manage that. When we, talk about being on the plateau, we're going to have to redesign the care that we provide in the health system in order to be able to safely care for COVID patients alongside our non-COVID patients. Right now, we have cohorted patients most patients are cohorted into COVID units, and we've tried to separate patients. We're going to have to see how sustainable that is going forward, but that is one of the things that we're thinking about. Certainly keeping some of our specialized units that have been taking care of these COVID-related patients for a long time as a place where that care will happen is likely going to be one of the solutions.
So this question, I don't know if we know the answer. How many U of M employees have died from COVID-19? Do we know?
I don't know the answer to that. So we would only know that for patients that were here, but I don't know the answer to that.
And we haven't had any here.
I don't believe so.
No. Yeah. So we can see if we can find out. But as far as what we've had, I think, I can't remember the number, how many.
So we've had on the order of about 10 employees that have been, 10 to 14 employees that have been hospitalized. Some of those employees have required intensive care. A number of them have been discharged. I'd have to look for someone. I think we published it on the update yesterday as to how many were actually still in the hospital, but I don't recall. Three were still in the hospital.
Right. But we've not had any deaths.
Not that I know of.
Do we have any information on the racial mix of patients we have seen in the ICU and general care?
So we're starting to pull that data, and actually I was just looking at some of that data earlier today. And I think part of what's maybe behind that question is early reports about differences in severity between races. So I don't have the information on the top of my head, but I think we have that information, and there is a